notes, which is quite good for reflecting on practice. The professional information you've got, making sure you're keeping the RCN and the NMC happy, how you can review your prescribing policies, and then just a quick clinical update to circle around that. I did decide to stay away from P formularies and hammering on about what most NMP leads go through. If you want that, there's space at the end to ask questions about, but I've tried to keep it a bit more general. So the first information, again, this has been out for consultation for quite a while, but the reason why I'm sharing this is normally reflecting on your own practice is very easy when it comes to which medicine you choose, whether there's a pathway, whether it's the right thing. Following actually what decisions and what discussions you have about prescribing can be incredibly difficult. And so this is just a really good, it's quite a short document because it's aimed at GPs, but again, it covers actually what decisions you're making, what you do when you know what's right for the patient and they don't want to agree with you. Usually that's the hardest part of it as a prescriber. I know what's right, why aren't you doing what's right? And it goes against everything that most people believe, but actually people can make bad decisions. People can make wrong choices if it's right for them. So again, how you deal with that, how you discuss that. This is a document, I think it just brings it really, really sort of nicely into context in real practical terms. So again, it's out there if you're doing any CPD reading, if you're doing anything for checking practice, you're doing anything for your revalidation, always worthwhile having a look. And again, as I said, obviously keeping whoever's looking over your prescribing rights, and with yourselves, the NMC and the RCN are key. Do keep having a look back. I was speaking at a local nurse a couple of weeks ago, and unfortunately, they flagged up that they were following all the updated prescribing guidance and showed me the RCN prescribing guide from 2016 as their Bible. Now that's great. It's a really good document. It's been surpassed now by 2 other documents. So again, it's making sure that you're up to date, checking these sites. They do keep it nice and similar, but it does update regularly. So have a look through there. You know, if you're doing a remote prescribing, there's a simple couple of pages to read on there, just so you know what the RCN says about that. If you're doing administration, if somebody asks you about transcribing, information on there, simple, easy to use. And again, these slides will be for everybody out there. Links work and everything else, I'm hoping. The next part of the update is just to remind you, this hit September time 2021, so it is fairly fresh. This is the competency framework for all prescribers. So again, this link works there. This is the Royal Pharmaceutical Society, so I do get a few odd looks from other professions saying, why should we listen to them? Actually, they're just the host organisation for this framework. All of those down the right-hand side have come together to basically agree what are the basic principles for safety with prescribing. You'll notice on there you have the Dental Association and the RCGP. These are medical prescribers that are even signing up to this. So again, this is across the board. When you're prescribing, what do you think about? How do you do it? And how do you do it well? It's really, really simple, about 18 pages long, but it just covers those key principles. Again, if you're reflecting on your own practice, if you're looking at how do you check whether you're a good prescriber, it's really simple to go through there and say, right, do I do this every single time? It's saying I should check for consent. It's saying I should follow up these things. Use this, go through the bullet points. Do I do this? Can I prove that I do it? If anybody challenged me, what would I bring up? And again, that's part of it. It's a very defensive way of looking at prescribing, but it's always a good way to say, if something wasn't perfect, have I been through this process? But again, do check this. It's the green background. If you've got one with a white and blue background, that's the out of date version. So again, good to upload for your revalidation, good to keep a copy of to prove. And the changes for prescribing programs. So in 2018, the NMC changed their standards for prescribing programs. One of the key lines there, probably for people already qualified, are the requirements. They're looking at the awards and the post-qualification prescribing practice. So again, this is everybody's got an eye looking forwards to when NMP becomes an essential part of degree level qualification. And most of the time when we're looking forwards, there will be a time when everybody comes out of university as fully qualified prescribers. So from that, it's how do you then guarantee if somebody's qualifying as a prescriber at between 20 and 25, Are they good enough to be a prescriber still when they're 60 just based on that qualification, or do we need to keep some sort of update? So that's looking at that. The other thing, especially for nurses and especially nurses that prescribe, is the competency framework for your designated prescribing practitioners. Now, I imagine if you've been prescriber for a few years, you'll have been overseen by a DMP, so a designated medical prescriber, that would have helped support you get your qualification and see you in practice. This is now expanding, so it can be any NMP. So this may be old news to you if you're training staff already. If not, again, it's a really good way of developing, making sure that the next generation, whoever's coming into your practice wanting to do the qualification, actually, if you fit the criteria, zip through, is an experienced prescriber and an active prescriber. So on this, really, really key, you can't just have a senior nurse that doesn't see patients anymore, or somebody that's never prescribed in that area overseeing the prescribing. It does have to be, like with everything, a GP can cover everything. An NMP, sorry, the rules are different. You have to be working in that area, aware of what's going on to actually support that practice. But again, you're wanting further staff, further prescribers, you've got that opportunity there. It is there. And you can use the Health Education Co-operative. So again, the link on there, this is a site. In some areas, you do need to sign up through your non-medical prescribing lead. So do have a think about that. If you want to have a chat with them to gain access. In some areas, it's just free, so you can go onto the website there, sign up. It will tell you whether you're allowed or not allowed, so you can go through. They have courses there. These aren't mandatory. These are just there for development. So there's the non-medical prescribing course, which is at the top. Right down at the bottom is the DPP course. That just shows you actually what do I need to know before I think about going forwards to be a DPP. So it covers the background, the governance, what you're being asked for. So it's a really free, basically it's a checklist. You go through, you have a look at actually what's expected of me in this role. What do I need to prove? What do I need to be aware of? On there as well, there's refreshers for your NMP. So again, for your CPD, if you're desperate for some revalidation, if you're thinking this would look good, then again, that's there on the virtual learning environment. So your non-medical prescribing leads will be able to give you access to this if you can't go straight through. So I'll pause there for questions. I see there's a few hands still up. So is it hands up for these things, or is it hands up in general? Anybody wants to unmute or put anything in the text? That's never good. I've got hands going down rather than hands going up. Nope. Okay. This is very dreadful with just my own voice. So just moving on to the next point of the most common questions that I get for NMPs, or the most shock, is when somebody qualifies normally as a prescriber, they're slightly surprised that I say that I have to wait until they appear on the register as a prescribing qualification. Now, all I'd say is it's a good thing to annually to check. You know, I know nobody likes Googling themselves and finding out what's out there on the net, but actually go onto the register, make sure you're registered appropriately. It's a really simple check. In the worst cases where you're not registered in your prescribing, all hell lets loose. So just worthwhile double checking that you can go through this. If you go through, you get a really simple thing, year that you're registered, and when you became an independent or supplementary prescriber. Don't be concerned about that bottom one. If you're an independent prescriber, it will always come up with supplementary in there as well. That's just how they record it. But it's just worthwhile checking that you are on the register, that you are valid. Otherwise, you can have a bit of a surprise. And as we've just had somebody driving without a license for 70 years, these things can happen, so it's worthwhile checking yourself. And again, a next point is, do you know where you're registered to prescribe? So being on the prescribing register doesn't mean that you're linked into your practice. You can check this simply by going through this. I won't labour it too much because it's a guide there meant to be just taken away. There's a guest login, so you don't need any registration on this website, and this has everybody that's registered throughout every practice that there is in England. So it is a PDF that comes down with 6,000 pages on it. Do remember, I'll go through, you can go follow that guide. My email's on this as well, so you can ping me an email if this isn't straightforward, but you can check this just to make sure where you're prescribed. Key times to do this is if you're moving between practices. That is absolutely key because you want to be removed from your old practice if you're not prescribing there anymore. so your name's not being used by them. You also want to be activated on the new practice. If you're working across practices, you want to make sure that you are actually fully registered with each practice. So it's a really simple way. Go on there, look for your PIN number, look for your name. Just please remember, when you go into this huge document, don't go scrolling, use Control and F. That brings up find on any of your portals or on the PDFs that you're using, and then you can go through and find where you're registered. If you've had a long career, you might find that you're registered in many practices where you never have been. The strange thing with non-medical prescribing is your same code can be used across multiple practices. With medical prescribers, that can't happen. Their code appears once. If they want to join another practice and prescribe it too, they need to make up a whole new number for them. So they need to exist twice on the list. Non-medical prescribers list once. The worst thing you can do for your practice is leave one practice, join another, and prescribe there without registering with the pricing authority. If you do that, all of your bills will go back to your previous practice. Nobody likes that because you're spending somebody else's money, but also the governance and the oversight. Question there for IP working in secondary care, only if you're prescribing within community settings. So this is just for the primary care element. I apologise. Just with this covers, but again, some of your trusts, in my area in Bolton, the trust has some community prescribing and some FT prescribing. So the FT often isn't listed on here in full. Most of the time it will be though. So if you're prescribing outside, if you're only prescribing within the internal systems within the hospital, this won't be registered on there. But if you're ever issuing community prescriptions or FP10s, good question. You remove the practice by contacting the practice manager. They have a nice little form to follow where they inform the NMP lead. So it's really, really simple. You just say, I'm on the list where I shouldn't be. Find your NMP lead, ping them an email. We ask you some really simple things. Very strangely, the BSA are obsessed what your title is, whether you're Miss, Mrs, Mr, Professor, Doctor, whatever it is, they need to know. They get very upset if they don't find that. So please, no one ever puts it in emails anymore because nobody thinks that Ms or Miss or Mr is important, but for them it is. You just fill in, say the leave date that you've left that practice, and it's cleared off on that day. So really, really straightforward. But it's a good way to check, especially if you work in lots of different areas, to make sure that you're registered and you're linked to a practice. Next slide. I know this is teaching grandmothers to suck eggs, but lots of people say you only do a report for prescribing once every 6 months that goes to the practice. Where can I get more up-to-date information about my prescribing behaviour? And the honest answer is that you can do that through your own GP computer systems. So all of them have a reporting function. All of them you can report via prescriber. So it's a really simple thing to set up if you're supported by CCG technicians. Certainly in our area, we use them to build our searches to find the patients where we present to practices, where we do key issues. They can find this within seconds. Otherwise, it may be practice manager, IT manager, practice support. You might get other admin support coming in that can run searches for you. It's really, really simple. If you set it looking over the past 3 months or over the past year, you can get a really simple report that just brings up exactly what you've prescribed. The ideal way of checking against what's on your P formulary and what you actually do. Can be quite shocking sometimes, where you spend years developing a P formulary of 100 drugs and then you find out actually you only ever use 8. And the 8 have got the least amount of detail in your P formulary. Sometimes you can find out that your competence, your experience extends past where you thought it was. So you can find that your P formulary is lagging behind. So it's a really good stop and check. If you get this set up just to show the latest 12 months or the last month, you can run that search whenever you choose to and find your own prescribing behaviour. If you're interested whether you prescribe for children or for adults, you can do a really simple search, how many over 16s against how many under 16s. You can do really simple things to check your behaviour and what's going out on prescribing. It is a bit harder if you're in foundation trusts. They do have electronic prescribing most of the time now, but again, getting time for them to write bespoke searches is usually quite difficult. So it's again taking it to your local leads. Normally they will shower you with just a complete data dump of what you've prescribed in the past year and expect you to work with it. please do give feedback about what would be useful and what would be informative, because again, this is data just being sucked out of a system. You can do wonders with it, but again, your feedback to them will really help them change that. I've seen somewhere it was just an email list that goes on about 7,000. I will. So after this, just seeing the questions asking for the links on this, the whole information is going to be sent out after this. So you're going to get all of these slides, all of the links work. And for moment, if you're working at MFT, usually they will have prescribing information that they will get. It certainly should go to your directorate or your department. Again, it should be coming to you as an NMP so you can find out what goes on. So speaking to your non-medical prescribing lead and saying, how do I see my prescribing information? There should be something coming out to support you and to go along with that. If not, you can blame me for saying that they should have that. But when you're prescribing, you should be able to find out your own information. And this should be coming back through because it should be part of your appraisal, part of your follow-up, part of your checks. It's really simple. So actually, if you're going through digitally prescribing, then that's fine. Unfortunately, if you're not digital prescribing, it's back to, I'm going to keep a paper record of what I've prescribed in the last month and go through and document what you're using just to double check. Long-winded, horrible. I really do hope you digitally prescribe and they can search for you because it makes life so much easier. And just remind them that it's not a one-off request. It's something that you really need ongoing just to make absolutely sure what you're prescribing. Because again, it should be even easier within a trust setting because you've got a very limited P formulary. With primary care, often that P formulary expands and expands and expands. So again, reviewing that should be a little bit easier. I'm just reading the question now. So depending on the prescribing systems, just one of the questions there is saying, are others included now? They are slowly improving. So depending on which computer system and which is registration, but again, they are catching up. So I do think recently we've registered paramedics in our area. So now I think System 1 does recognise that. I don't have any that have gone through EMIS, so I'm not fully sure, but most of them are doing updates and it depends when that update actually follows through. But again, it's one of those, you need the system to record you as your professional for that prescribing to work well. If it's not, if you're struggling, shout. NMP lead, I need to register, I need to prescribe safely. That means I need to prescribe digitally. Help me. And that's where we get on to the computer suppliers. That's where we got the updates escalated. That's where we know what's going on. Love to be ahead of this and to be aware of all of these things. But unfortunately, sometimes we need your help to flag up that actually we've forgotten about you. And it's not deliberate. It's often just right, next thing on the list. But again, the review of prescribing that you've got there, worst comes to the worst, pick February as your prescribing month because it's the shortest, get your piece of paper out and go through that to basically make sure that you've covered everything. What have I prescribed? Does it fit with my P formulary? The alternative way is print out your P formulary and just check, note down each time you prescribe something not already listed on there. And so that's the really simple checks. Getting a few questions, so hopefully this isn't too dull. Please do put in the questions if you want me to go and cover something completely different. But it was just, I'm really hoping, can I have a show of hands from people if they use the GMMG website or know what that's about? So a hand up if you've used it recently or know what it is. So most are showing there's still some gaps, so I'm going to blame you for going through this next bit. With this really simple website, it does change each month. So again, with that information, it does change, it does go through. It's been slowed down a lot through COVID because actually people haven't been able to free from their day job to go and support this and to go and help everybody. So it was just to make sure that you're aware of it. If you're doing your P formulary, this lot have already done the formulary. So these have got some of the information, some of the support that may be useful for you for developing your own. But again, you've got across the top there your home, so you can sign up there for the news, so the updates each month if you're really interested in that, if you've got a broad prescribing portfolio and you want to know what's going on. You've got the joint formulary, so that's broken down by the old BNF codes. Now, fortunately, I'm old enough to remember when the BNF was set up in chapters. No longer is it set up that way, but we still do it. So your endocrine section, your respiratory section are separate. It's just laid out that way. But again, it has that formulary, so you know what's covered. And again, the issue with this, it's a formulary for Greater Manchester, so primary and secondary care, but it's also meant to cover 80% of your prescribing. So when it comes to NMP, we're sort of thinking actually it should be more closer to 100% if we're taking out the odd prescribing that's there. But again, it's not foolproof. It's not covering absolutely everything. There are rules behind this. So if you do have pharmacists working with you, if you do have your CCG pharmacists or your hospital pharmacists, again, if anything's not in this formulary, checking why are we using it, what's going on, what's the reason is always a good thing. But again, that shows you 80% of your drugs should be in those formularies there. When you have the RAG and the DMP, this is red, amber, green drugs. So again, really, really simply, red drugs mean hospital or specialist use only. Prescribing should be in there, should be used. Amber means there needs to be a signed up shared care. Now, in most cases, because of the breadth of these drugs and how they're used, it should be a medical sign off for agreeing that shared care. All of them go from medic to medic currently, as far as I'm aware. So again, if you're asked to sign up to this, possibly sometimes it's worthwhile discussing this with somebody who's got a medical qualification to see if that take on is appropriate. And then we get onto the green. As always, 3 sections is really simple, but green is really, really lovely. There's green with specialist initiation. In my locality, that means the first month is always given by the specialist. So they start the drug, make sure that it's safe. It's usually for drugs where things can go horribly wrong on the first dose. So actually you need to know how to give it, what dose, why to give it, and you need to do it in a safe environment. You have green with their direction. So again, if you're told to do it as primary care, that should be safe. And then you just have plain green, which is everybody can use it first line, don't worry about it. We move on to shared care, which fits in with the amber drugs that I mentioned before. And then you've got the GMMG guidance. With the guidance on there, this covers for lots of things. So if you've got somebody who's wanting to go away on holiday, it's got guidance on there for actually what does the NHS need to do for that patient. It's got guidance on there if somebody's on a hospital drug. So we've had a push locally in Bolton at the moment with people who are on clozapine. So that's a specialist drug only through mental health services, reacts with most things known to man, really, really sensitive drug. Unfortunately, we're finding that that's being given in mental health trusts, but it's not being added onto the GP system, which would be really helpful. So when you go in to prescribe, we can utilise the computer system to flag up to say, bad idea, there's an interaction here. That's the first thing. It's entered in so you can't prescribe it yourself as a hospital drug. That guide is in that tab, so you can go and find that. But also it's on the Greater Manchester Care Record. So when that patient attends any hospital, A&E, another mental health service, any service, you can go on there, have a look at their care record, and it flags up clozapine. So you know, right, I need to be aware of this. Lots of other things on there as well. Once people have seen private consultants, what is the expectation of the NHS? And if you're dealing with things like high cost drugs, you know, the severely ill rheumatoid gastro patients, information's on there as well. And if you're really, really interested in GMMG, you can read the minute notes. So those are on there as well, publicly available. Again, really, really useful, absolutely essential that you use it. And I think second to last slide, don't know how I'm doing for time, but when you're developing your own P formulary, just some reminders of where you can get the information and the support. So obviously you've got the BNF. Knowing how to use the BNF is really worthwhile, and using the electric form. I know lots of people like a book and paper to skim through, but again, if you use the electric form, that will be up to date, that will be accurate. NICE CKS guidance is really good for just a really simple way of thinking about laying out treatment processes and what to consider. With this, NICE pathways used to be quite good, but as I logged in to find out, they're actually discontinuing this. So this is going to be removed. And if you're really struggling, many of the NICE NHS BNFs are quite difficult to search. They haven't quite caught up with Google to actually improve how to look for. So if you're looking for any of these, do just go into the Google search, put in whatever you want, BNF and the drug. It really does help you go straight through it. You don't have to dig through. So if there's a strange brand you've never come across, fire it into Google. It's usually much simpler than going through the BNF or the CKS website. Next point is GMMG. They've already thought about where it should be on the formulary. But again, I know we're Greater Manchester, but actually, surprise, surprise, other areas do some good things. So I've just put down there Pan Mersey, which covers sort of Warrington over towards Liverpool and the area around the Wirral as well. So that has similar guidance that GMMG does. Now, it doesn't mean you get to pick and choose, but what it does, if they're deciding about a drug or recommending something, they may consider it, whereas GMMG might have just said, yes, use it. So if you're building a formulary, they may have some really good information about that drug to support prescribers. The same with the East Lancs and the same with Derbyshire. Again, sometimes they have a lot more detailed on specific areas that they have an issue. That can be really, really helpful. And if you get really stuck, just stick in CCG followed by whatever you're looking for. If you can do on Google, go to the last 12 months, then you're just not getting something from 2010. But again, that simple type search can bring up something just to help you figure out how you want to explain to you something or to get your head round prescribing, to see if you do need a course, if it is something within your competence, and actually to support your practice. And the last bit there are other systems out there. We talked about digital nurse prescribing before with Health Innovation Manchester. One of the tools they put up was Smash. I'm hoping you have come across this. Sometimes it's aimed purely at pharmacists to use this, but actually the background information. So there's indicators on there for when you can usually over or under prescribe. So simple things of when you're adding in a PPI to a patient. Actually, if they're on aspirin, do they need it? Should you be adding in aspirin to somebody who's on an anticoagulant? There's lots of really useful information that supports that. That's a system flagging up, have you done this wrong? When they search through the system, it's using the care record to identify these patients, but also it's got the evidence behind it. So again, if you're doing anything, if you're prescribing aspirin, which is pretty common if you're doing any sort of cardiovascular system, it can be really useful. And again, ask locally, put your hand up, shout, scream. In Bolton, we have systems. So we have the Optimize RX or Script Switch, which I'm sure you'll have noticed popping up on your screen with messages. Do feedback. All of these have a feedback. If you think the message is stupid, boring, you never choose a selection, do feedback. But also there's other things. We have a digital system called DXS, which flags up pathways. We have med safety searches that are built. Sometimes we're not good enough to share. But if you ask, we'll make sure that we can remember and share it wider. So all of those things are options to support you building that P formulary and just assessing your own service. And then the last point, again, reiterating what you've already had with certainly Health Innovation Manchester, talking about the development, and with Shiny Minds saying if you're going to do CPD, make sure it works. And with this, absolutely key, you're spending your valuable time attending events like this, doing your CPD, doing your revalidation. In some cases, people will absolutely scream at me and say, I just want to do my job, let me do my job. But if you're doing CPD, do have a look out there to say, actually, can I do exactly the same course with some credits towards a master? Actually, if I'm doing 3 or 4 bits of training in CPD a year, actually within 3 years, I could get a diploma, I could get a certificate in this if it adds up. Is this something that's worthwhile? And all that is I know when it's normally panic time, when you get that notification that your revalidation date is due, and it's there thinking, right, I need to get out a few journals, I need to look at a few things, I need to do this to get through. It's that thinking at that point for next year, could I be spending my time a little bit better? And again, often the honest answer is no, I just need to survive. I just need to actually get through this. But with this, it's just stopping to think, if you want to do something around medicines about next step, do think about the time you're using and whether you could use it any better. As I said, in most cases, the response I widely get is, I'm just happy doing my job, move on. But do think there are lots of courses out there that offer those 15 credits and it could take you somewhere. So that's enough of my waffle. I've still got some hands up, which I'm maybe legacy hands. Does anybody want to raise any questions? Unmute and ask, or ask in the text. Or it must have been dreadful if people are saying it was useful. So Segunda.
Hi, just wanted to ask if there is any support for newly qualified NMPs in the primary care. And sorry.
So I was hoping there was Salford University put together a guide for newly qualified prescribers, which was shared with us in a draft form. As usual, it's the usual throwaway comment at the moment, unfortunately, which was before the pandemic. And since then, it hasn't actually progressed. So it went round to all areas of Greater Manchester for information. I was trying to get hold of it desperately for this event so I could share it, but I haven't actually found any examples that it's actually been published officially. So if there's anybody that's working in Salford that's seen this or gone through Salford University, it's part of their formulary, all the people I normally go to and ask haven't responded back to me. So I don't know whether people have moved jobs, been seconded elsewhere. But I will certainly, through this group, if it does come back, because again, it was really simple steps about actually how do I get onto my computer system? How do I do these checks? Actually, how do I have the conversation with my practice to make sure that my job description does now say prescribing? And all of these things, normally when you ask to be registered and it goes through the NMP lead, they should be asking these things. But again, often we're not perfect, unfortunately. So again, this was a really good guide to go through, but I will try and get that my hands on, even if it's a draft copy. You might have to have it with big bold draft letters, and I might have to take off Salford University's. But in essence, that was quite good. Don't know if anybody else on the call has come across that or come across any support, because again, I'm talking from a Bolton point of view. I know each area does things very differently, and we're desperately trying to catch up with ICB and doing things on a Manchester scale when it comes to NMP. So things might change vastly in the next couple of months as we get our heads around this and the governance that goes on with NMP. And so I'll turn it on to yourselves then. So very little support. So what's needed? If you had a wish list, is it the basics of getting onto a computer system, building a P formulary, challenging practices when they say go on, just prescribe everything that's on the repeats today? What is it that in hindsight should have happened?
Sorry, I'm thinking more the building a P formulary can be a bit challenging because you don't know you know if you've done multiple courses, then you can cover, let's say, the long-term conditions, and then you know, how much can you add on, and how can you increase, how can you make, you know, how can you work around everything like safely?
And certainly for our area, the challenge is normally driven by the competence that you have. And so that both means the practice that you're currently going through. Do you have the competencies, which often links to training and experience? So you're quite right, coming out of the NMP course, you've done that area to death. You know it inside and out, usually hypertension or respiratory. You know, you've absolutely then how do you extend that? And that comes from your development, you know, going forwards to actually have a look at it and saying, right, actually, you want me to go, I do hypertension, brilliant. I'm the best hypertension clinic nurse that you've ever seen. Drugs are quite limited. P formulary is nice and compact, which is why lots of people do it for the course. I want to go into respiratory, right? How would you evidence that you had competency in that? So training would be one, sitting in with other clinics would be another, reviewing what's on the G formulary is the ideal options. So that then gives you a plan to say, right, actually, if I can do all of these, I can demonstrate competence. That means I could go and work in there. And lots of that. And I can say that that's the sort of general getting that driven. But again, it depends whether you're supported in practice to have those discussions, whether you're getting that you know, PDP, appraisal, one-to-one, whatever that concept is within your service of, right, how do I move on to next? And again, it is very difficult because people say, oh, you're a prescriber, right? Respiratory clinic there, long-term clinic there, this clinic here. And it's there going, right, I need a good plan to develop myself on.
Thank you.
So breakout finishes in 5. Any other questions? It was me saying I like lots of interaction and lots of conversation, Leslie, and
I know.
people are just listening to
you, Joel.
I'm not
was
used
excellent.
to it.
It was excellent, and probably we need to think about that, how we support new NMPs and what we can do through this forum. So thank you for bringing that up, Saguna. You know, it may be a breakout that we have in the future that is just directed at new or under 12 months as a newly qualified NMP and what that support can be. And we'll definitely try and find out if Salford's press forward with that document, really, because that would be beneficial too. So yeah, that's great. But definite positive feedback there, Joel. So can you come again? We're going to do an NMP update at each forum. So you know that the quarterly. So we'll hopefully have an NMP lead from across GM doing May and then October and then later in the year. So come to them all. Should be good. Thank you. Thanks very much, Joel. Excellent.
Wonderful.
And the link to the whole forum will be sent to you today via email. So you'll be able to watch the presentations back.